Goedemorgen deze morgen. Good morning, everybody. And welcome to this symposium on global mental health and humane AI. As I'm sure you are aware, the occasion of this symposium is that we have 2 honorary doctorates today. Later today they will be handed out. The first is to Vikram Patel, and the first part of this symposium is dedicated to his topic, and that is global mental health. The second is to Chris Manning, and that is on humane AI. And the second part of the symposium was also dedicated to that. My name is Reinoud Wiers, and together with Claudie Bochting here in the first row and the next speaker, I lead the Center for Urban Mental Health, which is a collaboration between 3 faculties of the University of Amsterdam: the science faculty, the social and behavioral sciences, and the medicine faculty. And also we together nominated Vikram for his honorary doctorate, which is quite unique because normally it's only one faculty that does it. Of course, I can now give a long, lengthy introduction on why we chose to give or to nominate Vikram, but that will all be later today. And then it's a nice ceremony next door in the beautiful Lutheran church. And then we'll get all the nice words. Actually, Claudie will do the laudatio. So now we said it's actually very nice to get more to the content. So I keep it very brief because, you know, in the ceremony, for example, Vikram will only get 5 minutes, but now he gets, what is it, half hour or something. So we can actually hear content, so we're very happy about that. So we put together in the first part a couple of speakers related to the Center of Urban Mental Health and, of course, Vikram. And in the end, we'll have a little discussion led by Frank Kobbelens and also a spoken word artist. And then there will be a break, and after that we'll get the second part on humane AI. So we'll start off now with Claudie Bochting, who is my partner in crime in the Center of Urban Mental Health. She's a professor of clinical psychology in psychiatry, to also bring these fields together even more. And she's an expert on relapse prevention in depression. And of course, I actually got to know her when she got the prize for APP, for the best paper of the year, which was one of the first papers on relapse prevention in depression, in the Netherlands, of course, first trial. The nice thing is she also exported it, for example, to Indonesia. So it's really intimately related and interested in the topic of global mental health. Claudia. Classic. Claudie, the floor is yours. Okay.
Thank you, Reinoud. I'm not sure whether I exported something. I definitely did not, but I got the chance together with several universities in Indonesia to do a study on that. I'm going to talk about using technology as well as the community to target mental health conditions in low and middle income countries, and I want to disclose something. I only work a little bit on this, and of course the true inspiration to work a bit on this is because of Professor Patel. It's very simple. So why the urgency? Now, if you roughly look in 2090 at the prevalence of mental health conditions, then the estimate is that 1 out of 8 people live with mental health disorders. Of course, we faced COVID, and there is an estimation that it actually increased, for instance, anxiety and depressive disorders with 25%, but now there's a lot of debate whether it decreased and so on. So let's go back to before COVID. Prevalence is high. The most prevalent mental health conditions are anxiety disorders, depressive disorders, and of course, addiction. And some of you might think, or maybe none of you, because you're here and interested in global mental health and AI, might think, oh, this is only a problem in high-income countries. In fact, I always like to look at who is dying and who is not. Now, not really, I'm a bit of a morbid person, maybe, but 70% of the suicides, I'm not talking about attempts, but of the suicides are actually in lower middle-income countries. So that's the vast majority, and many of them are also determined by mental health conditions. In the Center for Urban Mental Health, we focus also on the impact of urbanicity, and you could wonder why. Now, because soon the vast majority of the people are actually urban species, live in urban settings. And we do now know that living in urban settings is associated with higher prevalence of mental disorders, especially, and that's something we worked on together with, I look at Eunice van der Waal and others, and Reinhard, of course, as well, especially if people, the majority of people, live in cities within a country. So it's a non-linear association. And what we try to do there is unravel the underlying mechanisms, but most importantly, we try to find new target points for more effective interventions, and not only focus on the individual, but also on group level, societal level. Now, it's clear that there is a mental health gap, and it's already years ago that the World Health Organization indicated like there is a disparity between the numbers of people with mental health disorders that are in need of help and that actually get it. And this is not only in lower middle income countries where 90% of the people do not get proper treatments, but also in high-income countries. The estimate is that sort of 50% of the people in high-income countries, like the Netherlands, who have mental health disorders still do not get proper treatments. But it's very clear that this is, of course, far more extreme in lower middle income countries. Now, there are multiple strategies to target that, and Professor Patel is definitely the pioneer on task sharing. And not only task sharing means that you actually try to unravel the most crucial ingredients of interventions and train non-specialists like lay counselors to also give these interventions. And most importantly, he and many of his collaboration partners worldwide examined the effect of these interventions in mental health conditions. And that is very important. And in the meantime, there are meta-analyses that actually indicate that these interventions, as applied by non-specialists and even by lay counselors, are effective in treating common mental health conditions. An alternative approach is the deployment of technology. Now, that sounds very broad, but for now I'm going to talk a bit about using the internet, e-health interventions, apps, and a little bit about chatbots. And why are digital interventions, why does it make sense? Now, there's a lot of evidence that digital interventions, especially when they're guided by someone, a specialist, maybe a non-specialist as well, are effective in high-income countries. There are a lot of meta-analysis indicating that. They are ideal for task sharing and also for retraining, because not only the individual, the patients, get the intervention, but also, given that it's usually with automatized feedback, also the lay counselor or non-specialist get constantly retraining. And it can be done from home. And this is important because in many countries, of course, there is huge stigma on having mental health conditions. So one of the things we did, and definitely this was not my, I think the university or many universities in Indonesia, and especially Reta Arjari, who is smiling there, did a lot of work together with me to develop an internet-based intervention based on very simple ingredients, and that's called behavioral activation. And behavioral activation is a very effective intervention for treatment of depression. We focused here on depressive disorders because depressive disorder is one of the most common mental health conditions with a huge impact, not only on the individual, but also on the people around them or their children, and even on society. So what we did together with Reta and many other people in Indonesia, we created an Indonesian version of behavioral activation in an internet intervention. It's important to remember, it's not only putting information on a website. People can fill in some things and they get automatized, personalized feedback. And this was guided by trained lay counselors. So people who didn't have like a full background, clinical psychologist or psychologist. No, lay counselors that were trained. And this was also remotely done from Indonesia. Important to remember, we included not people with mental health problems or depressive problems. These were people with moderately to severe depressive disorder. And the lay counselor, of course, this was inspired by all of the work that the group of Patel did, which already indicated that there's an effect. Okay, then of course you want to examine, does it do any good? So we did a randomized controlled trial and we included moderate to severely depressed people, and people got these internet interventions combined with lay guidance from a distance but within Indonesia, and the control group got psychoeducation, and this was information, the golden standard of information as given by the WHO on a website. And what did we find? We found significant lower depression scores, but most importantly, we also found a 50% higher chance of full remission, and this sustains over 6 months. And of course, we wanted to prolong the follow-up, but somehow the Medical Ethical Committee in Indonesia or in Jakarta didn't give us permission to do a longer follow-up. That is maybe because, a lot of stories. I don't know. I'm not allowed to talk about that. Maybe in the break. Importantly, we also found a true mediation. Dus we found indication that indeed behavioral activation was the working mechanism. So the change in behavioral activation preceded the reduction of symptomatology and even also remission. And this is important because recently also in the group of, again, Professor Patel, I am maybe boring one of them, but they also found true mediation of behavioral activation, not with a digital intervention, but this was a face-to-face lay counselor intervention. Interestingly, Eunice van der Wal also looked, maybe it doesn't work for the relatively low socioeconomic status group within Indonesia. And actually he found an indication that also for the relatively low socioeconomic status group in Indonesia, it works. You could say, if you're homeless, does it work? Probably there were no people in the study that were homeless, but we did include relatively low socioeconomic status group. Okay, this is all published. I'm happy to send you the article. And again, thanks to Reta Adjarda, who is now back in Indonesia, and she's now working on studies on suicidality and preventing suicide. Then, a couple of years later, together with Song Fang Fu, we wanted to know, is there now robust evidence that these digital interventions do any good? And is it also robust for other conditions than depressive disorder? So she did a systematic meta-analytic evidence published in Lancet Psychiatry, and this is what she found. She found overall a moderate effect size for depression, anxiety, addiction, and even also PTSD. But there were only a couple of studies on the treatment of post-traumatic stress disorder and only a couple on anxiety disorder. So the most convincing evidence of the effect of internet interventions were found for depression and addiction, and most studies combined it with guidance. So probably the guidance is important, because also otherwise the dropout is good. And these studies were literally from China, Iran to Colombia. There was no difference in the effects depending on the region. Are we ready yet? Of course we need more studies. But this is already a good sign that digital interventions indeed do the work, at least for depression and anxiety. So now, of course, you wonder, and now what's the next step? It's key to make sure that all these interventions are actually integrated in healthcare systems, including, of course, also the guidance. You have to have a sustainable model, and maybe Professor Vikram Patel later on will talk about it. And what's also so interesting, these findings are also transferable, at least partly, to high-income countries. For instance, we did a project inspired by this project together with Reta in Indonesia in the GP care, within our GP, with sort of our nurse practitioners, in Dutch, the POH's. And we try to examine if we give this intervention there, is it effective? Now, we only did this very small trial. We found some good initial results, but we definitely need to do a larger trial. It's also of interest for those who do not get to treatment, or actually they don't go to the mental health care centers because, yeah, they don't recognize that they don't see this is something for me, or because of stigma. And also maybe also to reduce wait list. By the way, we also tested this intervention, slightly adapted together with Reinout, within students who received burnout. This was a pilot study, so wait and see. But we found also for burnout good effects. So, are we there yet? No, we need more. So what's ongoing? It's really nice that we organize this together with AI. But of course, there are now also all kinds of chatbots that are studied. Some of them actually already indicated an effect. There's ongoing work on AI-based chatbots. And they are adaptive, so that's really cool. I know that Reinout works on that, probably also in the group of Patel and also with the WHO. We work on that. And what's very important within our center, we now try to see what if you try to target at the same time multiple levels. So for instance, in the ultra-high risk group, the individual, but at the same time the living environment. For instance, in the cities or in the parts of the cities where we know the prevalence of common mental health conditions are very high. So, digital interventions seem to be effective, at least for anxiety and depression in low and middle income countries, but in high income countries we already have a lot of evidence of that. And guidance seems to be possible and effective by people from the community. It's key to integrate, to get a system to integrate it in all kinds of healthcare systems. And global mental health studies in low and middle income countries actually bring us a lot. It facilitates not only innovation over there, but also here. Targeting multiple level might be promising, and this is also a bit of a bridge to the next presenter, Barbara, who is also part of our Center for Urban Mental Health, and she's going to talk about intervening on system-related level. It's important that I do not give away everything because then they will kill me. So keep it in mind, system-related level. And if you want to have a look what's actually going on in our center, please look at our website. And of course, I would like to thank everyone that did a lot of work to make all these projects possible. Some of you are here. And most of all, I'd like to thank you for your attention. Oh, dat is aardig. Gaan we zingen worden?
Thanks a lot, Claudie. We save questions for the end when we have a general discussion as well. Next speaker from the other faculty that nominated Vikram, and that's Barbara Schouten. She's associate professor in the Faculty of Social and Behavioral Sciences. She's a communication science. There's also psychology. This is where I am, but there's also sociology involved in the Center for Urban Mental Health, and education or pedagogical sciences. Barbara also leads this project on an EU project, Mental Health for All. And she's one of the PIs of the center, and we're looking forward to hearing her speak.
Thank you, Reinoud, for your nice introduction and for organizing this symposium together with Claudie. Congrats also to Professor Vikram and Chris Manning for your honorary doctorates. I'm Barbara Schouten, and I am indeed leading the Mental Health for All project, which is an EU-funded project that aims to promote access to mental health care services for refugees and other migrants that come into Europe and that don't speak the dominant country of the host country that they reside in. And as you can imagine, if you don't share a common language, then getting adequate mental health care treatment will be very difficult. So that's what we're focusing on. And if you recall Claudie's bridge and also the model of Eunice van der Wal, you see that migration is one of the meta factors influencing all kinds of multiple levels leading to mental health care issues. So I'm doing this project together with 8 other academic partners throughout Europe. They're both based in the south of Europe, in the west of Europe, and in the east of Europe. And you see here a picture of some of the people, actual people that are involved in the work during one of our partner meetings last year. And as Claudia also indicated, it's very important for the implementation of an adequate intervention to involve also adequate practice partners in the project, so that's what we're doing as well. As Reinhard already said, I am a communication scientist. I have been trained as a psychologist a long time ago, so I'm a bit of both, actually. But we're trying to tackle this problem of access to mental health care service from a multidisciplinary perspective and have included psychologists, linguists, patient representatives, and so on in the project. It started last year, so what I'm going to do today is just give an overview of the aim of the project and the contents and present some of the first results, but we still have 2 more years to go to further develop and evaluate our intervention. So before I dive into the project, I just want to give some contextual information about why are we focusing on these low language proficient refugees. Well, that's because there's a huge problem with professional interpreting services. There's no regulation, directives whatsoever at the EU level that secures these patients' right to professional interpreting, and that means that also EU member states often do not have any policies, regulation, guidelines that help bridge the language barrier in a professional way. At the same time, there are hundreds of languages spoken in the EU alone and also provided by interpreting services such as Global Talk, which is the main Dutch interpreting service, but they're not being used as much as we would like to. And the implication of this is that many treatment sessions are being done by family members, untrained interpreters to bridge this language barrier. And just to give you one example of the extreme consequences that can have, you see here is the cover of a book. This book is about Willie Ramirez, and this is a famous case in this field. Willie Ramirez was an 18-year-old Cuban-American boy that went out for lunch with a friend of his, became unwell after lunch, was rushed to the emergency care because he lost consciousness, and there was no professional interpreting at all available there. And some of his family members were there, his mother, mother-in-law, who tried to explain what might have happened to him, what might be the case. And they used the word intoxicado. And intoxicado in Cuban Spanish means feeling unwell because of something bad you have eaten or drank, but very understandable, the emergency physician mistranslated it as intoxicated. He also saw a Cuban boy, 18 years old, and thought, oh, this might be a drug overdose, and he treated him accordingly. But actually, he was suffering from a brain hemorrhage, and that was left undetected for a couple of days. And in the end, he became paralyzed for life. So this is just one example of what can go wrong when no professional interpreters are being called in. Now, as Claudia also indicated, the prevalence of mental health issues is disturbingly high, 1 in 8 worldwide, and in the EU, 1 in 6 even at the moment. And when you look at the sheer number of refugees that come into the EU, mostly from Ukraine because of the Ukrainian war last year. So these are numbers from 2022, but also from other countries like Syria, many people fleeing from war. And if you translate that into numbers, we are facing millions of refugees and other migrants that do not speak the language adequately to communicate with a mental health care provider, but are in need of mental health care treatment. There is also a lot of literature coming up the last decade about these groups of people, and basically these reviews and meta-analysis show three main problems. In the first place, the prevalence of certain mental health issues is higher among refugees and other migrants compared to non-migrants, and we're talking about post-traumatic stress disorder and depression. At the same time, they don't have as much access to mental health care services, so their access is hindered by a host of language-related but also culture-related barriers. And even when they gain access to these mental health care facilities, the risk of dropout of premature treatment cessation is higher compared to non-migrants. So there are a lot of problems that needs to be tackled, and that's where the mHealth for All project comes in. And we try with this project to promote access for these groups of people to mental health care services by developing and evaluating a multilingual communication platform, information and communication platform, which contents are based on existing evidence and also new evidence that we are collecting at the moment. And we're focusing on these different dimensions of access, so availability, approachability, acceptability, and appropriateness. So we're trying not only to increase the literal access to mental health care, but also to make mental health care more culturally sensitive. And for now, I'm just focusing on the first two dimensions shortly, because that's what we worked on the last year. And turning to availability, that just means increase the availability and the ease of access to existing resources. And this can be patient leaflets, culturally sensitive mental health care facilities, guidelines, and so on. We quality assess them by means of different criteria and have now come up with a first prototype of an information portal or database that can be used by both clients or potential clients and by mental health care providers to look up resources that can be helpful in bridging language barriers by selecting the country that they're based in, the languages that they're interested in, and the type of resource that they are looking for. Then the next dimension, approachability, is going one step further. So it's not enough to just make these resources available, but also to train patients, clients, and mental health care providers to understand how to make use of these resources to tackle the barriers. And we are doing that by developing multilingual patient educational videos, so in the mother tongues of the patients, so that they're understandable, and by developing e-learning modules for mental health care providers. And the content of both these patient information and mental health care provider trainings will be based on research that we are doing right now. We have done a rapid literature review, a survey among different types of mental health care providers, ranging from social workers to psychiatrists, and an interview study among patients and among interpreters. And I will give you some of the results of the first two studies, because the patient study is very difficult, also because of ethical issues that I'm not wanting to talk about right now. So let's move to the results of some of the results of the rapid review. And what we found, one of the things that we found was that there are main barriers that are shared by all stakeholder groups, so patients, informal caregivers like family members and friends of the patient, and providers when it comes to the main barriers to accessing mental health care, such as patients being not willing to disclose certain symptoms because of fear of stigma, of losing face, of being afraid to be abandoned by their communities, but also an inability to disclose certain symptoms and cultural differences in emotion expression, for instance. And what's interesting, and what's only mentioned by patients, is that they think sometimes that mental health care providers have inappropriate conduct towards them, like stereotyping, ethnic discrimination, and cold and not empathic behavior. On the social level, there's a huge lack of mutual trust between the two parties. And on a system level, and that's basically what we're mostly focusing on in this intervention indeed, they indicated there's a lack of good interpreting services, a lack of culturally validated screening tools, and negative attitudes from the healthcare system towards patients. Kind of, they didn't use the word institutional racism, but that will come up, I'm sure, in the next couple of publications on this topic. So going to some of the results of the survey, what you see here on this slide is are the mean scores on an item that asked the respondents for their perceived accessibility to mental health care services. And basically what you see here, the scores range from 1, the lowest perceived accessibility, to 10, excellent accessibility, that all countries except Lithuania score below the average of 6. So respondents think that the perceived accessibility is inadequate. Then these results show what happens when these people come into treatment. And we asked them about the frequency of communication difficulties mental health care providers encounter when they treat patients with a language barrier. And what you see here is that all countries, almost all countries, I should say, most of the respondents indicate that they encounter communication difficulties often or always, except for the Eastern European countries, Lithuania, Poland, and Slovakia. They score a bit less negative. And we also asked them, okay, when you do certain tasks like a therapy session or triage or physical examination, so when do you experience these communication difficulties? And one of the answers that stuck with me is that even if you can get a professional interpreter in a treatment session, for instance, when you care about patients in an inpatient care facility, there are many contact moments when you have contact with these patients but cannot establish any therapeutic alliance outside the treatment session because of the language barrier. You don't share a common language with them, so that's a big problem, for instance, for inpatient care. We also asked them which communication strategies they currently use to bridge the language barrier and which communication strategies they deem that they find least effective and most effective. And interestingly, in accordance with the lack of policy, family members are being reported to be most frequently used by most respondents. And in the second place, there's also huge marketing going on right now. Online digital translation tools, just like Google Translate, we all use them also for our own work. They are quite often used. They're also heavily promoted in healthcare, mental health care, but they are perceived as being least effective. What they actually want, and that's the green numbers, is professional interpreters on site. They think, okay, we need professional interpreters, but they're not being used by they're being used by 55% of the respondents, but it should be increased, of course. Then we asked an open-ended question: what is now the top 5 ranking of barriers that you can think of? And they mentioned a huge number of issues. It was quite a challenge to analyze. About 1,700 different issues were mentioned, but we could categorize them into 5 main general themes and 5 language-specific themes. And what Claudia also already indicated, there is a lack of available mental health care services overall, so also for the entire population. But the distrust issue, the lack of trust, came up again in the open question. Negative attitudes towards migrants from healthcare staff was reported in this study by mental health care providers for the first time. So that is something that is in accordance with the patient's views. And the language-specific themes, well, already mentioned, a lack of good interpreting services, lack of good information material that is adequately written for these migrant patients. And when asked about the facilitators of access, you see kind of a mirroring of these results. So what they want is access to good professional interpreting services, good informational materials, and training for mental health care providers. That we will do that to become more culturally sensitive and adequately treat these patients. So our next steps, based on all these results, is to develop further the content of our platform. This is a still from a short video that's being made by one of our partners in Belgium and Brussels for VEDASIL, which is the Belgium asylum-seeking organization. And what you see here is a still of an instructional video on how the TVC screening is taking place. So every refugee does have to go through a TVC screening. And what they're doing is using both videos and animations. And we know from research that animations can work quite well. So we're going to use the same format in our own contents. And that was it. Thank you.
So thanks a lot. And the next speaker is Vikram Patel. You'll get all the laudatio later this afternoon. Just want to mention Vikram Patel is a Harvard professor of global mental health. He's a leading voice on the topic and edited an important series in The Lancet on the topic, which was very influential. And he's not only an academic in the ivory tower, but actually also involved with a lot of work on the ground in India and other places. So without further ado, I'm really looking forward to hearing your talk.
Thank you. And good morning, everyone. First of all, I want to just express my deep gratitude. I'm humbled for having been nominated to receive the doctorate from this great university. I will, of course, speak more about that later this afternoon. But thank you very much to the faculties that nominated me, and to particularly the two of you for having put my name forward. It's really an important thing to recognize that when subjects like mental health are acknowledged by these awards, it's not me personally, I think, but really the subject that gets the spotlight. And I hope that this is only the beginning of what might be a very wonderful collaboration between our groups. So as you've heard, I've mostly spent my whole life working in the Global South, initially in Zimbabwe for a few years after I finished training in psychiatry in London. And then I have lived in India till 2017, when I was recruited by Harvard Medical School, where I joined the Department of Global Health and Social Medicine. There I had the privilege of working, currently have the privilege of working in an incredibly interdisciplinary faculty comprising medical anthropologists, sociologists, economists, historians, and of course, the whole range of medical specialties. And it's a real telling signal that if we are going to actually shift the needle on global health issues, and of course, as you'll hear in a moment, the global health issues include the wealthy countries of the world, we're going to have to work through an interdisciplinary lens. I want to spend most of my lecture today really speaking about a group of interventions that I think are central both to the prevention and care of mental health problems, and those are psychosocial interventions. I'm going to focus almost entirely on care, but it's important to remember that these are equally important for prevention. In a nutshell, psychosocial interventions are those interventions which target two different kinds of mechanisms through which our mental health is mediated. They are primarily either psychological mechanisms, these are internal mechanisms, or social mechanisms. These are related to mechanisms in our interpersonal relationships, or indeed our relationships with broader social and structural forces. These are amongst the most evidence-based of all interventions that are known in mental health. In fact, as you will see, this is a kind of a little summary of the large body of evidence of which mental health conditions they are effective for. And as you scan this, you will realize that, in fact, they're relevant for every single mental health condition. I would suggest that there isn't a situation of mental health care where either a psychological or a social or a combination of these interventions will not help the person in the recovery journey. And for some conditions, the very common ones like anxiety and mood conditions, in fact, they are by far and away the most effective. For depression, for example, where you do have a choice between pharmacological and psychosocial interventions, all the meta-analyses clearly show that while these two are equivalent when you consider short-term outcomes like remission. If you look at the long-term outcomes, in fact, psychological interventions outperform pharmacological interventions in terms of reducing relapse. So the question is, when you have such a strong evidence base on these interventions, how often do people actually receive these interventions? And I'm going to use the case study first of the US, because of course the US is the world's wealthiest country, not just in terms of its GDP, but also in terms of mental health resources. It has the world's highest density of mental health professionals per capita. There are more mental health professionals in New York City than in the whole of sub-Saharan Africa. It spends the most on mental health care, almost all of it on highly qualified specialists working in hospitals. So it's germane to ask the question, how well does the US perform in terms of access to these incredibly effective interventions? It turns out it does very badly. In fact, when people consult for depression, the overwhelming majority of individuals will receive a prescription after a 5-minute contact with a primary care practitioner. The vast majority of people will not receive psychosocial interventions. And what's ironic, of course, is that the very groups that are more likely to be affected by depression because they bear a disproportionate burden of the social determinants of depression are actually even less likely to receive psychological treatments. And this is in spite of the fact that they are more likely to prefer psychological treatments. And of course, as we all know, if you get the treatment you want, you're more likely to engage with it, and therefore you're more likely to benefit from it. Now, I often ask my students who I teach at the medical school, let's do a thought experiment. And I'm going to do a thought experiment with you. Imagine we were talking here about breast cancer. And imagine you had 2 different interventions for breast cancer, A and B. A was associated with lower relapse rates. A was the intervention that women preferred. Imagine a situation where the health system only made B available. That is actually what is happening in the US, and in fact that is also what's happening around the world. In the parts of the world that I've spent most of my life working before I went to the US, in fact almost nobody gets psychosocial interventions. Mental health care in most of Africa, in most of Asia, is equivalent to a 5-minute prescription. That's what mental health care looks like for the vast majority of people who even get to mental health care. And that is why I completely agree with Tom Insel, a very prominent American, a very strongly biologically oriented psychiatrist who's had an epiphany in recent years. He was the director of the National Institute for Mental Health, which is the world's largest mental health research funding body. He published his wonderful book last year called Healing. It's very locally focused. It's focused primarily on the US situation. And what he really describes is that the crisis of mental health problems in the US, where every metric, every single metric of poor mental health has worsened in spite of its spending more than $25 billion only in 10 years on mental health research, in spite of all the riches and resources that the US has. Every metric has worsened. And of course, it's an interesting situation in contrast to, say, cardiovascular disease or oncology, where spending money on medical care and on research has actually led to profound improvements in those, in the trajectories of those conditions. In the case of mental health, it looks like almost everything gets worse no matter how much money you spend. And what he rightly says, this is not a crisis of the lack of political will. It is not a crisis of the lack of money. Clearly, the US has a ton of money. It is not a crisis of the lack of physicians and mental health professionals. The US has many of those too. It's a crisis of care, of making fundamentally wrong decisions about the kind of care that we offer, and the fact that those decisions are guided not by science, but actually in the US almost entirely by professional hierarchies and commerce. So what's the opportunity? I often think that the greatest opportunities to challenge the big problems of our world come not from wealthy countries, but it comes from those countries in the world where resources are scarce and where people have to do innovation. In India, we have a word called jugaad, which doesn't really easily translate into any into any European language, but it really means improvisation. improvising with what you already have, because actually, if you relied on the government and you relied on some future kind of, huge amount of wealth coming your way, you'll be waiting forever. And so you've got to improvise here and now, using whatever little you have in your communities to actually address the big problems that you face. About 12 or 13 years ago, or maybe 15 years ago now, Tom Insel approached me to co-chair for the National Institute for Mental Health, along with Pamela Collins, a research priority setting exercise. He had already begun to sense that the almost complete, overwhelming investment in biological aspects of mental health was yielding almost nothing of value in shifting the burden of mental health problems. And he said, well, look, maybe we need to look to the global south. We need to look elsewhere to see what might be innovative and new solutions to this issue. But we don't know what the research questions are, and so therefore, could you do a research priority setting exercise on the basis of which the NIMH will then provide new funding to actually support those research questions? And that led to this publication on the grand challenges in global mental health. It was really primarily a paper that was directed at research funders. In the last 15 years, the NIMH and many other research funders have put out at least a couple of $1 billion of new money on backing these grand challenges. The grand challenges, perhaps not surprisingly to any of you in this room, were not about discovering a new gene, a new neural circuit, a new molecule. It was actually about doing better with the evidence we already had, in some cases for 50 years. It was about making sure we could bridge the no-do gap, what we often call the gap of delivery, the implementation science questions that needed to be addressed to deliver interventions for the prevention and care of mental health problems. And today, as I stand before you, I can tell you with great confidence that in fact, we do know how to bridge the no-do gap. And as I'll speak about in a moment, these are equally relevant in wealthy countries, because no country in the world has addressed mental health problems effectively. And in that instance, every country in the world is a developing country when it comes to mental health. And I don't think you could say the same about cancer care or other aspects of medicine. In mental health, you can certainly say that. So this image reflects one of the more than 100 randomized control trials of innovative strategies that have been used to address the no-do gap in low and middle-income countries. This image comes from my colleague Dixon Chibanda's work in Zimbabwe. And what you can see is, and I'm going to talk about that image a little bit because it actually tells you something quite powerful about some of the ingredients of these innovations. What you can see here is an elderly lady sitting on the right-hand side on this bench and a woman with a baby on the left-hand side. And the back of that bench is a building, a brick building. That's actually a primary health center in the city of Harare, one of the most densely populated urban spaces in southern Africa. The woman that you see with the baby is a mother who has been detected to have significant depressive symptoms by a nurse in the clinic at the back. And the woman on the right-hand side is, dressed like a nurse, but she isn't actually a nurse. She's a grandmother from the local urban slum community in which this clinic is located. Now, you might ask the question, what is she doing? Well, she's been trained to provide a 6-session brief psychological intervention based on CBT. Then you might ask the question, why is a grandmother delivering this intervention? Well, why not? For a start, grandmothers, it turns out, in Zimbabwe are very nosy people. They know everything that goes on in their local neighborhoods and communities. They're interested in what's going on. Most importantly, they have nothing to do with their time. And in the culture of Zimbabwe, they're highly respected because they're elders. So Dixon did a very clever thing. He deployed these cultural facts and these demographic facts and said, let's deploy grandmothers to do something that's purposeful for them, but it also is acceptable to people in this community. And let's see if we can train them to deliver a brief psychological treatment. And then let's conduct a randomized control trial to estimate what the effectiveness of this intervention is. This is really, in a nutshell, a story that can be copied in all of the 100+ randomized control trials that have been published in the last decade. In my own work, I worked primarily over the last 25 years in India with a not-for-profit organization called Sangat. And these are, I'm not going to go through any of these, but these are just simply to say that this is probably one of the most pioneering organizations as a mental health research institution, which works with government systems across the country, across the full range of prevention and care for mental health problems across the full range of conditions, from autism in childhood all the way through to dementia and old age. And what this large body of evidence has done is, well, it's been reviewed in a number of systematic reviews. In fact, the most recent one is published in the Cochrane Library. These are a couple of examples of reviews of this innovative set of strategies for two very different groups of mental health conditions: the serious conditions like the chronic psychotic disorders and the more common mood, anxiety, and trauma-related conditions. What this large body of evidence is doing is it's helping us reimagine mental health care in four very distinct ways. First of all, what comprises mental health interventions? We can now no longer simply say it's a prescription in 5 minutes. But equally, we can also say that the psychosocial interventions are designed to be very brief, as short as sometimes a single session, so that you can optimize the feasibility and acceptability of those interventions. They're designed around very clearly specified active ingredients that target pre-specified mechanisms of action, which I think is extremely important for our field, to embrace the notion that we can't simply be shooting in the dark. We need to have pre-specified, hypothesized mechanisms, and as Claudia described rightly, we need to test empirically, in fact, whether our interventions are acting through those mechanisms. And that we need to have those interventions not being narrowly defined only by one domain of the mechanisms of mental health, but as I mentioned in the terminology I used, both psychological and social mechanisms that can be tailored to the individual's specific context. The intervention should be provided where people are, not where the professionals are. Most of these innovations are delivered not in hospitals and clinics, but in fact in the community settings where people live their daily lives, in schools for adolescents, in primary healthcare where they go for their general medical issues, but in fact in a lot of my own work, particularly for chronic conditions like autism, in the home. And sometimes people say, can you really deliver? I mean, where do you deliver healthcare in homes? Well, actually, in many other areas of chronic conditions like TB, it's been a tradition to, in fact, deliver interventions in people's own homes. Who delivers the interventions? It certainly isn't mental health professionals, because they don't exist in most parts of the world. It's deploying whoever is available in the health system. A lot of my work has been with community health workers in India, but in fact you could have nurses, you could have midwives, you could, whoever is available. Instead of sitting around saying we need to train more highly expensive specialists, especially in the global south, that will mean specialists who will migrate the moment they finish training to the Netherlands, for example. Let us train people who are unlikely to migrate. Let us train people who live and work with the patients that they're going to treat and share a common social and cultural environment. This is not simply about filling a gap because we don't have specialists. It's an altogether a radically different way of thinking about how you create a culturally sensitive workforce. Well, I think it's very interesting. We first of all train doctors and nurses and then train them to be culturally sensitive. Actually, when you work with people within the community, you already start, in fact, with a workforce that is culturally sensitive. And I think the important question of the how is never to see this approach as a replacement for the mental health care system. Not at all. It's intended to expand the footprint of the mental health care system deep into the community, to reach the last mile, to reach the populations and subgroups who have historically been excluded from the mental health care system. And so I always call for this approach as being one that must be joined with the existing system through collaborative and coordinated care systems that have also been heavily evaluated and described. Now, this body of evidence, 10 or 15 years ago, if I had spoken to an audience, usually a mental health professional, they would have said, this is very ideological, but you have no proof that any of this is true. This very large body of science, which I believe is probably the single largest corpus of delivery science in the mental health field to emerge in 5 decades has already demonstrated huge impacts on policy and practice. On the left-hand side, you see major documents from the World Health Organization and the World Bank that have embraced this idea as the primary source of reaching the unreached in all countries of the world. And on the right-hand side, you see country-level documents, the mental health policy of India, and then, of course, the RAND Corporation report on reforming the US mental health care system. It's very interesting living in the US now, finding how much interest there is in actually embracing these ideas within the US. In fact, the Biden administration has a massive new mental health a bipartisan funding plan. This is interesting as well. I was talking earlier, there's huge political will. One of the only issues in which both major parties in the US agree on is that the US needs a better mental health care system. And what both parties agree on is that we need to break through this idea that all mental health care requires specialists in hospitals and empower members of the community to do so. And that really is, And that really requires us to invest at the base of the pyramid. But the base of the pyramid of care, that shows you a classic, the pyramid of care, where, I think you will all be familiar with this, that, most care should be provided close to where people live, in community and primary care settings, but currently most care is provided at the tip of the pyramid. Certainly most money is spent at the tip of the pyramid in highly specialized settings. I want to end by telling you something in the next 10 minutes. I'm going to go a little quickly so there's enough time for questions, of something that's exciting me a lot and what keeps me occupied and interested in the work I'm doing. I'm no longer asking the question, does it work? But I'm actually now asking the question, how do we take what works to scale beyond the experimental studies that many have been conducting, including Claudia and others, in different parts of the world? And we have to acknowledge that there is an issue here, a big question here. Imagine for a moment if what I described to you was a pill. I don't think we would be having a discussion, how do you scale this up? Because, of course, the commercial incentive to scale up would have already done it. It's fascinating how medicines with small effect sizes are scaled up overnight. Well, fascinating only because we sit around with such effective behavioral interventions and are completely unable to scale up. There is an important elephant in the room that we have to acknowledge here. That as academics, we assume that somebody else is going to scale it up, then I think we are wrong. This is not an intervention with a clear commercial incentive or gain, and therefore we as academics are going to have to engage with the messy world of scaling up to actually make sure that these interventions get to people who need it. What we have to embrace is that one of the most important barriers to scaling up, in addition to the lack of commercial incentives, is that the traditional methods for training and supervision that are needed to scale these interventions up have been largely dominated by the experimental studies, where a lot of focus has been on ensuring that experts do everything. And that, of course, again brings us to a bottleneck. We also rely heavily on in-person methods for training and supervision. And over the last 5 years, I have been working with a team, a very fantastic team of people, both in the US and in India, and also with a number of global advisors, to build out a platform that enables us to deploy digital tools and technologies and methods to rapidly scale up these evidence-based interventions. And this is a program that we call Empower, which is currently being deployed both in the US and India. Our mission is really to train people, anyone and anywhere, to master the delivery of evidence-based psychosocial interventions. And what we've developed is a suite of different tools, methods, and procedures that will allow us to do that. In the first step, and this is a crucial step, is identifying the intervention you want to scale up. So I do not believe in the branded approach of psychotherapy or psychosocial interventions. Do you know, In the US today, there are more than 700 packages of care for children and adolescents with mental health problems. Every single academic lead will develop their own intervention, usually then add the name of their university to signify that intervention. The irony is we have 700 intervention packages, and most kids in the US don't actually receive any one of them. And so we have to move away. In the same, I use the analogy of the pharmaceutical sector to generics. And the generics in the psychotherapy and social intervention field is the active ingredients that I referred to earlier. The brief, mechanistically informed active ingredients like behavioral activation is for depression. And we spend a lot of time making sure that we work with those active ingredients using non-proprietary manuals that have been utilized in randomized controlled trials and as our starting point, and which are then vetted and accepted by the global experts in those particular conditions. We then, well, yeah, I'm going to go quickly here. So we have really identified a set of active ingredients that, that span the full range of mental health problems, from early distress, which of course, one of the other important innovations is you don't need a diagnosis to receive care. So distress is really where you have the initial symptoms, as it were, or emotional experiences associated with distressing events. And you can see our target audiences are, in the US, very important, but in India as well, is faith-based communities. Faith-based communities are very actively involved in the US in reaching out to people in distress. Then you have incipient mental health conditions. These are when these distressing symptoms become more persistent, more sustained, and begin to impair your daily functioning. And again, we have a range of different interventions. And then finally, after acute clinical care, for those who have chronic conditions to promote recovery, you have psychosocial intervention. So this is a range of different mental health contexts that Empower is building out the curricula. We all know that it's not just sufficient to have a manual. We've developed methodologies for blueprinting the curricula around a set of core competencies, evaluating those competencies, both knowledge and skills, and then, of course, always co-producing all of this with our target audiences. And then finally, we work directly with partners. Those partners, in our view, are no longer research project partners. These are partners who directly employ and salary the frontline workers. In India, as you'll see in a moment, these are the community health workers of the government of India. In the US, we're working with community health workers and frontline nurses and social workers who are employed, for example, by hospital care systems. And over the next few months, Harvard Medical School will launch out its own spin-off that will allow all the Empower products to be directly available and contracted to implementers in the US and abroad. I'm going to skip this in the interest of time. I want to say something about the deployment of technology. Technology lies very much at the heart of everything that Empower is doing. These technologies include very simple ones like off-the-shelf learning management systems, somewhat more sophisticated technologies that we've specifically developed with tech companies, such as technologies that enable frontline workers to supervise each other and assess the quality of care using quantifiable tools. The technologies for assessing competency assessments, and very recently, and I'm really looking forward to Christopher Manning's work as well, the deployment of machine learning methods to be able to actually provide automated assessments of the quality of therapy by using pre-recorded and coded therapy sessions. I want to finish by giving you an example that really illustrates how this will work with a specific intervention that we designed and developed and evaluated about a decade ago, a 6-session treatment for based on behavioral activation for people with severe depression, which we designed and was delivered by lay people in primary healthcare settings in India. Very similar to Dixon's work, actually. This intervention was then subsequently adopted and trialed in Nepal with very similar results, in fact, led by a Dutch colleague, Mark Jordans, and his team in Nepal, and has subsequently, quite fascinatingly, been embraced by investigators in the US. So there is now one of the largest trials of perinatal depression ever conducted in the world. It's being led by a team in the University of Toronto, University of Chicago, and UNC, funded by the US government, that took this treatment, designed in India, reverse engineered it, adapted it for mothers in the US and Canada, and is now running one of the largest psychotherapy trials evaluating that. This intervention was adopted for good reason. This shows you the initial trial results. After 3 months of receiving the intervention, 65% of people with severe, this was not just any depression. This was severe depression, the most severe form at the end of the spectrum. 65% responded. This remained sustained at 12 months. And with colleagues, economist colleagues at MIT, we've just conducted a 5-year follow-up. Think about this, a 5-year follow-up after 6 brief sessions delivered 5 years earlier, and you still see sustained benefits that separate the 2 arms of the trial 5 years later. Very few interventions in mental health can actually speak to this kind of sustained effect. With NIMH support, we demonstrated that a carefully designed online curriculum available, sorry, it's offline, it's digital, but delivered offline because most of our health workers don't have access to the internet in the villages they work, was as good as the gold standard of expert-led in-person workshop-based training, but especially effective if you had a remote coach supporting the training. We then got a grant from Grand Challenges Canada to build out the peer supervision and quality assurance app. I'm just going to show you a couple of screenshots here, which shows how, for example, the health workers can view the quality ratings that they have made of therapy sessions in comparison to those of their peers, and if needed, and wherever available, an expert. And as I speak now, the first a cohort of real-world frontline workers in central India, in 3 rural districts of the country, have now been deployed. More than 1,000 have completed training and are now beginning to deliver the 6-session BA treatment to others in their community. This may seem like a small number, but remember, this evidence is only 7 or 8 years old. And so in many ways, you have to look at the whole sort of timeline from where this evidence was generated and where we're scaling up. But what's really fascinating for me, having now moved to the US, is how much interest there is in the US to adopt these approaches. Enough interest that when we started work with some support from a foundation in the US to begin to reverse engineer these interventions for delivery in the US, we hardly expected that the place where we would have our first opportunity to roll out would be Texas. And well, yeah, it just goes to show that one has to question some of our stereotypes about different parts of the world. It turned out people in Texas were so enthusiastic about bringing global innovations to their communities. We won a prize, a $10 million prize called the Lone Star Prize, which had been advertised as to any group that could do something dramatic to help improve the lives of Texans who were affected by the pandemic. There were bids on racial harmony, on water harvesting, etc. It turned out the philanthropy committee chose a bid, which was about improving access to depression care using community health workers. So I'll end here. There's another example of adolescent and school conditions, mental health problems, which I won't spend much time on. This is my last slide. I want to end by simply saying that business as usual in mental health care will simply not work. Pouring more money into a system that has already really shown very dismal or disappointing results is simply pouring money down the drain. I would argue that we do know what to do. We have the political will. We have demand in the community. It's important for us to embrace the evidence that exists. But for that, and I don't know how many of you in this room are mental health professionals, we have to learn to give up some of the power that we have vested in ourselves, in our professional skills, in our communities, in our hospitals, in our clinics, and give up some of that power and be able to support the empowerment of a much wider church of individuals to be involved in this essential task. Thank you very much.
So thanks a lot for this wonderful talk. The next part, I invite Frank Kobbelens, Professor of Global Mental Health here at University of Amsterdam, and he leads the Institute for Global Health and Development, who gives some comments and then lead the Q&A. And after that, we end the first part with a spoken word artist, Daniele Zawadi. The floor is yours.
Thanks, Reinhard, and thank you very much for this very inspiring lecture. I was introduced, and this may be in this company probably a well-known term, a Freudian mistake, that I'm a professor of global mental health. Actually, I have no idea about mental health at all. I'm an infectious disease guy, but I was actually in poverty-related infections. But I was actually very much inspired by all these talks, because I saw so many correlations with what is happening, what has happened, and I think has happened rather successfully, for example, in the HIV field, where there was a major health crisis, which through concerted effort in the end was addressed at a global scale. We're not yet there, but I think we're doing well. In my own field, tuberculosis, sort of the same thing. And I see a lot of very relevant parallels here. Dr. Patel, you mentioned some elements that I think are sort of very interesting here. For example, your vision is really to scale up interventions that are locally, culturally appropriate, that have proven efficacy, of which we know what the underlying mechanism that is being addressed by the interventions, and that are for which it is hugely important to sort of build it onto the existing health system. So taking into account the fact that you shouldn't do something completely vertical, but you should make sure that there is this integration with the health system. I think that is hugely important. Is as important as it is here in the high-income countries. It is important in low-income countries. I very much actually liked the four elements that you mentioned: the what, the where, the who, and the how. And I think that is exactly how in global health we should think about new interventions and improving, or actually closing the gap, because I think everything in global health is about closing a gap between demand or need on the one hand, and basically it's closing the access gap and availability and approachability and appropriateness of intervention. So thank you very much for that. And I think also we've heard in the other two presentations by Claudia and Barbara, we have heard sort of similar elements. I think a very important element that has come back is the combination of psycho and social. I think it is really very important to, and I think that is your field is doing that as probably even more than my field is doing, that the social environment, in addition to the system environment, is hugely important for health in any respect. I think we can't see health, and I think you all basically came to this notion, we can't see health separate from its social environment, and we can't see it separate from the system. I think the other thing that I found sort of really resonating is that there is a very clear view, as I see in global mental health, as to where it should be going. It is basically about task shifting, but not task shifting for the sake of task shifting. You made that point very clearly. It is not just to say, well, we have a human resource crisis, and maybe like a bit in surgery. I mean, it's very difficult to have surgery done by people who don't know about surgery, or who haven't had at least a sort of proper training. Even though there are things now changing here with simulators and things, and there's a whole lot happening here. But if you look at the global surgery crisis, that's primarily an HR crisis. It's a crisis of human resources. It's a crisis of specialist force. Whereas I think you've made very clear that this is not so much. It's not so much that the interventions that are proposed with regard to of which you've shown that they're actually very effective, with regard to make use of lay counselors or make use of professionals in the health system. You mentioned, for example, midwives, you mentioned nurses that have not been originally trained for doing mental health interventions, that you are not proposing this to close this gap primarily, but because it has a value with regard to health outcomes in itself, which I thought was, that I'd never realized that this would be the case. And to me, this was the sort of the real sort of lamp that started sort of what's the right term here? Shining in my head. And the other thing I think we've heard about is its language, and I think the translation of this hugely important element in refugee mental health care in Europe, and I think we are here really looking at a crisis that needs to be addressed. Although I was really thinking, well, how on earth are we going to address the problem of language if refugees in the Netherlands have to sleep outside in a high-income country, for God's sake, have to sleep outside an asylum seeking. Anyway, I can get really very angry about this. So how are you ever going to solve this problem if you don't solve the very basics of refugees, which is shelter and which is food and all these kind of things? Anyway, but I think you made it very clear, and I think the translation of language into what you have been showing us is really into this sort of embedding in the cultural setting and embedding in the community. And I was also interested by the fact that you mentioned it's not just bringing mental health care close to homes, but actually bring them into the homes. And then, fortunate for me, you gave the example, and as you did, of my favorite disease, which is tuberculosis. And I think this is also an important element, I think, to mention, because this is the example of a poverty-related disease which has been neglected I think, to a large extent, and I think that's true for many mental health problems as well. They've been neglected because they've been with us for such a long time. They've been with us since humanity, and that also means that very often they're just taken for granted. And that I think that's true for a number of these poverty-related infectious diseases as well. So I know I've been just trying to make up for the fact that I don't know anything about mental health. But I wanted that just to summarize with this, and then basically start the Q&A. How much time do we still have? 10, 15 minutes. Okay. Who can I give the floor? Shall I? Maybe I should sit here, or okay. That is there any? Maybe. Yeah. That's a question.
Good morning. Thank you for your presentation. What will be the hardest struggle to implement? If you see the locally, you suggest a local approach. What will be the hardest struggle if you look into the world, different cultures, different situations, different? There's one question, and the second question is the biggest struggles with. What I like about your approach is that you give trust. You trust people that they solve things, and what is lacking now in the system that there's a lot of distrust.
Yeah, let me start with the second question. I think you're right. I have drawn a lot of inspiration. It's really good to have a non-mental health person here, because actually most of what we do in global mental health is a copy-paste of what's been happening in other fields of global health. People think this is innovation of global mental health. It's not. This is an innovation that comes from maternal and child health, actually. It goes back 50 years, from China's barefoot doctors movement all the way through to India's frontline workers for reducing maternal and infant mortality. That's where actually this innovation comes, of deploying community members. And trust is central to that, because you're more likely to trust somebody who wears the same clothes as you, who speaks the same language and shares the same neighborhood, than some physician wearing a white coat who treats you like, honestly, in most of the health systems in the world, in a very hierarchical and very patronizing way. It's very hard to trust, when there's such a huge power imbalance. Power is at the heart of how healthcare is organized in most parts of the world. And that addresses your second question, is what is the biggest challenge? It is that power hierarchy. And that power hierarchy works in very subtle ways. Doctors are superior to non-doctors. Non-doctors, like nurses, are superior to community health workers. And at the lowest end of that power hierarchy are so-called ordinary members of the community, who are dismissed as knowing nothing and should never question how the healthcare system works. Now, this may not be the same in the Netherlands, of course, but this is what happens in certainly many, many countries in the global south. And upsetting that power hierarchy is a singular task that we have to engage with. And as I said earlier, that means giving up some of that power actively and in a very intentional way.
I think so. Maybe Wendy first and then Joop. Yeah.
Thank you. You clearly described how these psychosocial therapies are really the most effective, and that has been shown by like 100 RCTs in low and middle income countries, and now you call for scaling up. What I wonder is to what extent we also know that in a scaled up manner these interventions still work, because then people are not as well trained, we don't have these researchers on top of it. So to what extent can we be confident that the effectiveness will be...
So I wanted to just say one thing before I answer your question. I don't want anyone to misunderstand, and I don't think you are, but I just want to make sure. I'm not suggesting there's a competition between psychosocial and pharmacological interventions. That should not be the message here. The message here is that we must offer what works to the person who's receiving care, and what we are not doing is that. We're often offering them a second option. In some instances, pharmacological interventions are actually extremely important and are what works. So I think we should just keep that in mind. The question you're asking is a really important one. Does it work at scale? We don't know the answer to that because that process is only now beginning. And I think what we need to do, therefore, as I mentioned earlier, is move away from experimental designs, which really only ask the question, does it work? It doesn't actually address the implementation question. Who does it work for at scale? What are the characteristics of the context that influences what works for whom? There are some very interesting, very complex questions because they actually interact with the messy real world that we all occupy. And we as scientists are not comfortable with messy things. So it's easy, it's much more comfort, it's a comfort zone. Let's do a trial because it's much easier to control in a randomized control trial. Implementation science is very, very difficult. And I would encourage those of us who are interested in scaling up to embrace the methods of implementation science, because that's where the answers will lie. And I would just end also by saying a lot of our energies in the mental health world, particularly in the global south, and I don't know if it's the same here, is training people. If there's one thing that we know from implementation science is that training itself is ineffective. Let's first of all just make sure that if you ever see an initiative that says we went and trained 1,000 teachers or 1,000 nurses and there's nothing that follows up, how did we supervise, support, and do continuing quality improvement? Then you can be sure it's a useless program. No point actually doing that. And that's a good example of implementation science, demonstrating that the effects of training alone are very short-term. If you don't have anything that follows up beyond training, you unfortunately see no long-term results.
Okay. My name is George Banker. I'm nutritionist, healer, and so on. Peace professional. I worked in Sri Lanka soon after the tsunami. So now I wonder if India will be the biggest country in like 5 years. If another tsunami would then come up, maybe more people in India would listen to the radio compared to watch television. Would there be a possibility to do prevention of post-trauma stress syndrome by maybe 2 radio broadcasts and see that so many people are not going to be in deeper trouble?
Yeah, I think I firmly believe that you're right. I think using mass media, both radio and TV. TV is also very powerful, actually, and there's a fascinating literature on how television soaps have been used. So you can't make it too educational; it gets boring. No one watches TV, to get bored. So you have to weave the educational component, almost keep it hidden so it's not obvious. And that requires a particular script writing talent. And people have done that. There's a wonderful example from South Africa where the target was gender-based violence, but obviously if you present the soap in that way, no one will watch it. So really make it a soap opera about a woman's story, and make it, full of gossip and intrigue and mystery, but actually underwritten in all that is a range of different public health messaging. And there's a similar thing in India as well. A very successful, one of the largest soaps in terms of viewership has been a soap for running now for its third season on women's empowerment, but again, not presented like that. And so I think there is a real potential for many of the simple techniques that we use in the mental health field to be disseminated through mass media.
Vikram, thanks for your beautiful talk, and Barbara and Bhakti as well, Claudie as well. I wanted to ask you a methodological question to solve a dilemma. We were trying to set up a program in California after the wildfires a couple of years ago, one of the richest parts of California. And then while we were setting up the program, I was shocked. I started to compare figures, and then I realized that here in the Netherlands we have per capita 10 times more GP, 12 times more psychologists, 15 times more psychiatrists, and 440 times more nurses compared to the rich part of California. So then we thought, how are we going to solve this? And then the rest of the people who weren't rich there in that wine-growing area were all the Latinos who came over to pick the grapes. And they were all having 2 or 3 jobs to survive. And then in such a situation, what kind of method would you follow to get into the communities and to find out who could help you to solve the issues you just mentioned?
So, again, one size, the US is like India, it's a hugely diverse country, and so one size does not fit all. But I can only speak from my work in Texas. I think the most important way to identify who is through actually consulting people who are in the community. So, for example, I had not expected, the example I'll give to illustrate this point is the importance of faith. I had never really known how powerful faith-based communities are until I actually spent time in Texas. And I discovered that these are communities, they're very different. There were so many different churches. I was, first of all, amazed by how many different churches there were. But they all had this enormous sense of moral purpose by helping others. And what was interesting is that helping was not only other members of your church, but it was helping members of your community. And there was a profound awareness that I received that I have worked so much within the health system, I have never worked within the faith system. And it struck me that actually this was a human resource that was already available, that was committed, that was supported, and importantly accepted by people in the community. I need to actually figure out how I work with the faith-based system. Initially, we're secular, I'm secular person, and I always think of faith as maybe not being necessarily part of my landscape. And I walked away from Texas, and I used to always think faith was important in Africa. Traditional medicine. We all come with those stereotypes. It turns out I've never seen faith more important than in the US. And so now I work a lot with the faith-based system.
Thank you. Last question.
Thanks, Dr. Patel, for a great talk. I'm very fascinated by this topic. One part that jumped out to me was the statement by Tom Insel that the mental health crisis is a crisis of care. Because you also talked about how rich the US are and how many resources there actually are for mental health support. So my reading of the situation would be that the mental health crisis is a crisis of inequality. Definitely in the US, but also here in the Netherlands, where mental health support is, only vaguely part of the insurance system, for instance, and access to care is much greater in people who have the money for it. So do you agree with this? And if so, I can imagine it's usually frustrating to work in a context like that, where these large political and economic issues are also at the root of mental health problems and access to care. I guess my question is, how do you deal with that there's this injustice in society that then changes how you have to solve the problem of mental health care?
Yeah, no, you're absolutely right. I think you hit the nail on the head. There is, of course, at the root of these inequities lie historic prejudices and inequities. And, both the countries I know best, India and the US, are saddled with extremely complex histories of injustice. So you're absolutely right, and I won't pretend that, the work that you do can be seen out of context with those bigger historical injustices. You have to do what you can in your own small way. And I always strongly believe that there are very few mythical individuals like Martin Luther King or Mahatma Gandhi who we admire and think, they changed the world. But honestly, it's the actions of individuals, ordinary individuals, when collectively in solidarity with one another, which actually then make big changes happen. And I see this in the US currently with the issue of racism. It isn't any single figure. There is no one figure, actually. But it's through the actions of countless individuals that you can begin to see a movement towards addressing this terrible, terrible sort of issue that has affected the well-being of all Americans, not just Black Americans. And so I think that's how I position my work is, I can't change the history of the US or India. I cannot change those structural forces alone, but in my own little way, by, for example, working with Black and Hispanic providers in Texas, I can at least change the narrative of who a healthcare provider can be.
Thank you. Thank you very much. I think there is much more. There will be much more to discuss with you, but I think that we leave that for the break. Back to you.
Thanks both, and we like to end the first part in a special way with a spoken word artist, Daniela Zawadi. She actually also performed in our Urban Mental Health Conference last November, did a wonderful job. She talks about being young in the Netherlands and with a bicultural background, which is now actually, especially in the big cities, the most frequent existence, you could say. So we're very happy you're back here and happy to give you the word.
Good afternoon. I'm going to be sharing two pieces about my own mental health. I wrote these almost 2 years ago, so right before the start of the pandemic, and how I was confronted, like most of us, with what it meant to suddenly be stuck in a certain space. I've never felt so tired. Everything I do is what I want, and because of that, this is a waste. Because now I do all those things tired and late with less passion, and as the saying goes, you can only do what you want and then scream things like, I do what I want and I'm having fun. I do what I want and I'm tired. Tired of being difficult and making things difficult when it can be easy, because easy is when you're not tired, but from this point on I am, because from this point on it's a little trickier. Because I'm dealing with things like 12 hours of sleep, 2 hours of free time, and then a laundry task of time, and then I'm 3 hours late and tired in my eyes, which hurt every time I whirl them, and so I make a circle with my entire body to see that this is the earth. And so the world keeps on spinning, and I try to keep up with more difficulty than before because my eyes can't keep up anymore, so let alone my steps. My voice is hoarse because I haven't used it in a long time, and I only want to use it when I'm saying that I do the things that I want and I'm having fun. So as long as those words will not leave my lips, it will be another voice that you'll hear, another voice that actually fits in the picture a little bit closer to things like better than last week. I'm taking my time, I'm doing it like I do it, and I'm fine because I'm doing everything I want, but it's harder than I expected. And I expected a lot, because in like all the movies and books, there's always a conflict at some point, so I was ready. Because the NS, they would fail me, and the weather also wouldn't work, and friends are not really there when you're doing what you want, so I had backups of a life that I planned before 2020. So for now, I only have my common sense. which is also tainted by my unhealthy body sense. A little slow in accepting that these are some slow days. A bit crooked because I still use that thinking as something healthy. A bit weird because I still use it as a frame of reference instead of all those alternative plan Bs. Because for there, I bathe. In the oh-so-long nights. There I sink in an understanding that in the real life I'm dreaming everything I want. Until it rises to my lips. On the tips of my toes I push myself up, a little jump in the air to breathe and imitate the Olympian flare because that's higher than human and it can probably save my fatigue. And after that I reach my peak and I sink down, immersed in black. Because that's what they say the future is. That's what they say death is like. The future is black and beautiful, and I'm only one of those things when it's daytime again. When I try to remember my bodies and my muscles, how many years they have to go. So let me stretch my muscles, let me connect them, ache them, sour them, explain that this is going to take a while, so don't you dare relax. And my common sense is the organ that keeps on sending out all these messages because healthy is not used to unhealthy and will keep on telling healthy what healthy would tell healthy, and that is it's okay not to be okay. It's okay to be a little bit slower, to follow your dreams and not to be happy because you're hopelessly tired, in need of a slower pace than you're usually wired. So I don't want to use all my energy to hate. I keep an eye on my sanity for my own sake because even though I puff at every step that I take, I still want to meet other people, to talk and to share experiences because that's rich in value, in knowledge and in love. That's how it goes. Thank you. And then I want to wrap this up with a piece about something that I think we all might be familiar with. The title is also immediately the first sentence of this poem. And it's called Writing an Email is Not That Hard. I got all the necessary applications installed in my smartphone, and I should be able to respond to that one email after my coffee break. Actually, I do not like coffee, but I still take that break. And then I pick up my phone and oh dear, there are 200 emails waiting for my response. Can I do a follow-up on the follow-up for the follow-up of next week? And did I hear about this new job application that will close its window within 3 hours? And how did I not know that yesterday is in 3 days from now and I am responsible for the baby shower for my friend's nephew's baby nephew? And there's my therapist having a burnout and she will take a few months off, says that I should too. To all the friends from high school, we're organizing a reunion and no answer means yes, means a follow-up on the follow-up for the follow-up of next week. That's actually not right. I only have 2 emails waiting for my response. But the feeling is the same. So let's put this phone on mute for the entire day. And let's have it formulate a gravitas that does not obey the laws of physics. And let it be so powerful that it will pull you awake in the middle of the night. Because that's when the keyboard smashing is the loudest. That's when insanity starts to take over. Because my Google Calendar says no, but my responses are, yes, of course, what time would be suiting? How high am I jumping? And will there be a pillow thick enough? And will you join me in this madness? Since I see we are both trying to keep up, but none of us are trying to break this chain. So I expect a response from you before the end of the next day, before the older generation and the one below us will start calling us insane because this is okay. I'm just asking and wondering whether you're also not afraid. Yours truly, truly. Writing an email is not that hard. Dear 20s. Will you become kind on me when I start doing yoga? Or when I open up those paper government letters? Because the others are having so much fun, because they're smiling in their pictures, because they got time to be taking pictures. Dear 20s, I don't want to plan you in my 30s. I don't want to regret you in my 40s. And will nostalgia be kind on you and put on a nice filter? And will be that something that I'll talk about when I'm older and later and reminisce about this moment? Dear 20s, no one told me that writing an email is not that hard. And I should have known. You never wrote me one. Thank you very much.
Thanks a lot, Daniela Zawadi. Wonderful job again. We have a coffee break now, and at 11:30, the second part for the Honorary Doctorate of Chris Manning will continue.
Hi, so welcome back everybody. Welcome for those of you who have just arrived. So very glad to have this public symposium on the occasion of the Honorary Doctorate that will be awarded this afternoon to Professor Christopher Manning. I want to start with a little introduction on sort of my research fields. And my research fields, we scientists sort of like, I think many of us sort of identify with the great discoverers, right? So some of us sort of regret not having lived in the 16th century and having all these sort of exciting discoveries still to be made. So we want to sail the world, but now we do this in our own fields and find the sort of the unknown territories. And this can of course be extremely exciting, but as we know from those old days, once the discoveries are made, things can also go terribly wrong. So we need to sort of reflect. That's one thing we can learn from this. We need to reflect on early enough on what we're going to do with all of this new knowledge that we're discovering. And I think my fields, artificial intelligence and natural language processing in particular, also very much the fields of our honorary doctorate, are now at that stage that we've arrived at sort of at new areas in the space of possibilities. Have new knowledge, but we urgently need to reflect also on how we're going to use that knowledge. So what's so revolutionary? Let's start there with this new technology. Now, that was for a couple of years sometimes a bit difficult to explain to a broad audience, but in the last few weeks, like the whole world seems to have been discussing this technology from our area called, and in particular, this model called ChatGPT. Now, you will hear quite a bit more from it from Chris in a moment. But this is an AI technology that is sort of part of a trend over the last few years, where these models have become larger and larger and larger and larger, and they've reached these sort of insane sizes that we a couple of years ago didn't think would be possible, trained on enormous amount of data. And once they reach a certain stage, they start to sort of show this sort of uncanny, fluent behavior. So, many of you might have seen many of these examples. I just picked one here in English that was in the New York Times, where you can ask it to write a poem about any topic. In this case, it was about the false, the fake news about vaccines. You can also ask it to translate. So this is translating from Dutch to English, and it actually does an extremely good job at sort of translating a classic poem from Dutch literature into English. And the same technology, so what's powering all of this is this model called the transformer model. We don't have the time right now to actually go over the details of such a model, but that same technology is now, that comes out of our field, the natural language processing, is powering all this sort of revolutionary developments in neighboring fields. So it's behind what's happening in the protein folding, this big breakthrough from last year. It's used in the domain of music. It's used in the domain of speech. It's used in vision, in recognizing images. It's used to generate images from text. So we have these wonderful examples where we can sort of type in a sentence like an art gallery displaying Monet paintings. The art gallery is flooded. Robots are going around the art gallery using pedal boards, and boom, the system generates these images. Many other examples. This one was in The Guardian just a few months ago. It's used in the domain of mathematics. It's used in the domain of programming, very importantly, and in the domain of logic. And so there's this wave. There seems to be no end on sort of the impressive results that people are getting. So it's, to me, very clear that this technology will be very disruptive, right? it will be very disruptive. It will change things in society. And it will change many things for the better. And I'm glad that this morning it got also, mainly mentioned in a sort of a positive sense. There's amazing opportunities coming up for chatbots, for entertainment, for education, for productivity. But there will also be this sort of worrying developments that we need to steer, right? And that's why we're so happy, again, to have Chris Manning here as an honorary doctor, not only as someone that has been pushing the developments of this of the technology and the scientific insights, but also someone that has been very early in calling attention for sort of like the need to think about the consequences that this will have in society. So my own journey here is also like lots of my career is sort of following Chris Manning at a polite distance in research area. So I think we are also very much at Amsterdam looking at all of these issues in what we call responsible AI. And I just want to take a moment to sort of like maybe explain you very, very briefly why this is so difficult. Why it is so difficult to sort of ensure that this technology is actually not producing hateful or discriminatory output, and or why it's so difficult to actually provide explanations for what that people deserve when their lives are affected by this kind of technology. And it has a lot to do with the lack of transparency in these models. So let's have a very, very quick look and ask that question: why are these models not transparent? Why is it so difficult to figure out what is happening on the inside? And I want to give you a glimpse of what's happening by contrasting it with the way we used to do things. So when we used to do things, say 20 years ago, when we were building, or 30 years ago, or 40 years ago, when we were building sort of language technology, maybe for translation, maybe we wanted to translate the sentence, Barbara reveals that George hates broccoli. This is a sentence from 30 years ago, or 40 years ago. Into Dutch, we want to end up with Barbara onthult that George broccoli haat, and not with this wrong sentence where what we would arrive at from the word-by-word translation. So we used to sort of say like, okay, this is what we need. In order to do this, we need to know what the grammar is of English, and so we would actually we would have technology that would actually analyze the grammatical structure of those sentences and sort of find out sort of that there are noun phrases and verb phrases in there and entire sentences. And then only when we had sort of like analyzed sort of the grammatical structure of that original sentence would we then sort of think about sort of like what would be the equivalent in Dutch, and then we would make our translation. Well, we did lots of wonderful and work in this area again, and so we call this sort of the symbolic and probabilistic methods that were so dominant from the 1960s onwards, and got this extra sort of very powerful, strong power when we added probabilistic methods in the 1990s and later. I'm going to skip this. And from those days, all of us in our field remember this particular textbook that was published in 1999, and that was on all our shelves. That was the standard that you'd go to learn about these advanced methods. But in the last 10 years, things have radically changed, and people have largely thrown out this technology and replaced it by a style of modeling where we first translate all of those words in the sentences that we want to translate into rows of numbers, and so we call these embeddings or vectors. And in fact, one of Chris Manning's most cited papers is a very famous method for doing this, the GLAV model. And then once we have these vectors, then we sort of like we we pipe them through this deep learning technology, neural network models that sort of like that can do magic with these numbers. And inside those very deep inside those neural networks, and we train them and train them and train them and train them. There, the actual analysis of the linguistic structure, of the meaning of words, of the meaning of combinations of words is happening. But we don't know anymore how exactly that works, because the models learn that autonomously from examples. So how can we make them more transparent? Well, that requires a lot of research, and I personally believe that that research is a key to achieving a lot of these sort of the goals that we set ourselves in responsible AI. And so I'm going to skip over this, but there's all these different approaches that are around, and sort of in my own group, we've sort of like in the last 10 years focused enormously on that challenge of making this more interpretable. Again, very often following just 1 or 2 years behind key results that were coming out of Stanford NLP from Chris Manning's research group. Take-home messages for today. We need to be working towards more responsible AI technology and NLP technology. And my personal sort of take is that requires better interpretability technique. And then once we have these, we can sort of actually build better bias monitoring and mitigation strategies. But more generally, in our journey, we need to reflect on what this technology is going to mean, what this knowledge that we're achieving is going to mean for society. And to do this, I suggest what we really need is we need people on board in the ship to climb into the mast and sort of get to a very high position and take this very long view on where things are going and what might go wrong and what might go right using this knowledge. So we need people that are willing to sort of actually climb up the nest and get into the crow's nest and sort of shout when land is in sight or when danger is in sight and tell us about this. And as candidates for manning the crow's nest for the next hour or so, I have invited Marietje Schaake and Christopher Manning to present to you sort of their views on developments. And Christopher Manning will be first.
Great. Well, thank you very much, Jelle. And it's great to be able to talk to you today a little bit about ideas about human-centered artificial intelligence and natural language processing. Today I want to introduce the idea of what human-centered artificial intelligence is and to discuss some implications of this topic that arise in my own area of computational linguistics, otherwise known as natural language processing that Jelle has just introduced, or NLP, where we're trying to get computers to do intelligent things with human languages. Like many other people, I've been somewhere between fascinated and horrified by the dramatic videos that Boston Dynamics now regularly releases. I think all of us, when we see these kind of demonstrations, we fear that we're only one step away from robot soldiers coming to hunt us all down. But I think we shouldn't actually be so scared of that. These Boston Dynamics robots are very cleverly programmed and they have great control systems, but they don't actually have artificial intelligence. They're no more artificially intelligent than an Airbus A320. They're very much hand-designed human control systems programmed by human beings. And besides, if we're going to be hunted down, well, starting from about 15 years ago, the United States had sufficiently advanced communications networks that it has the ability to hunt people down pretty much anywhere, making use of human intelligence sitting in North Dakota to use with autonomous aircraft. So we already have different ways to have killing machines where the interface for the human being looks a little bit too much like a video game. So I don't think that we really need to be fearing so much what AIs will do on their own. Rather, I think we have reason to be worrying about what people and organizations with power will use AI to do. The rise of the internet and social media was meant to lead to a new era of free information, democracy, the positives of free political thought, and improved human lives. Unfortunately, that hasn't actually happened. Rather, powerful people and organizations have mastered the new technological options. Machine learning has provided new tools for surveillance and control. Although big cities have long been filled with video cameras, for most of their history, the cost of storage and human review of video evidence meant that its use was extremely restricted to cases where the police were involved for a genuine law enforcement concern. But nowadays, we have cheap computer storage and computer vision techniques where it's possible to do cheap mass monitoring of societies, and that seems what's genuinely scary. There is no doubt at all that AI is now taking the world by storm in all kinds of areas. There are many positive and good uses of artificial intelligence, from scientific discovery with tools like AlphaFold, natural language processing giving very good speech recognition and translation, other things like AI-driven fashion design. Artificial intelligence can definitely transform society for the better. But we also need to consider carefully how and where to use artificial intelligence. So speech recognition is now both extremely accurate and provides a method for powering human input to computers or communication that's much faster than texting with thumbs that we all have become so good at doing. At the same time, neural machine translation, as Jelle alluded to, is now really quite good. We can find content from other parts of the world, such as perhaps a news item in Swahili, and stick it through machine translation and find out immediately what people in different areas of the world are thinking and seeing what's happening to them. If you put those two technologies together, we're on the verge of having the artificial intelligence version of the Babel fish, where people of different countries and languages will be able to communicate without the traditional constraints that have held humanity back for thousands of years. So much of this has been enabled by artificial neural network models, models of word and text meaning that mainly came to the fore from 2010 on. As Jelle already introduced, these models start off from the weird place of taking human language and turning the words of human language into vectors of real numbers. But that's proven to be an extremely powerful idea because these vectors represent in a high-dimensional vector space give a very good representation of word meanings along multiple dimensions and the similarities between the meanings of many words. That was followed by a breakthrough in 2018 when people discovered how powerful it could be to build large language models. Starting with only sort of large language models with 100 million words of training, people have made the size of the neural network and the size of the amount of data used bigger and bigger by orders of magnitude, powered by the revolutionary neural net transformer architecture that came out in 2018. In principle, how these models are trained is very simple, and it doesn't really seem like it should lead to artificial intelligence at all. So basically, these large language models are trained to play the game of Mad Libs, that you're given either a context to the left or on both sides, and you tell the computer to guess which word should be appearing in the gap, and if it guesses correctly, it gets a reward. If it gets wrong, it has a loss, and we just repeat this over billions and billions of times. We're building a word prediction and context machine, and so that seems like it shouldn't really be much of anything at all. It should just be a very clever system for predicting type ahead like you get on a mobile phone. But it turns out that when you do this at a large enough scale, something revolutionarily different happens. Because once you're training on billions of words and hundreds of billions of prediction tasks, it turns out that the model discovers on its own that it can do this task better if it knows about lots of other things. If it knows about the grammatical structure of sentences, that helps it predict the word better. If it knows facts about the world, if it knows that Amsterdam is capital of the Netherlands, then that will help it predict which word to put in different sentences. And so we have these models that have enormous amounts of knowledge of both language and the world around them. It's indeed, just surprising the extent to which this works. So Jelle already mentioned ChatGPT, but I thought I'd better put in a ChatGPT example. So I asked ChatGPT, write a conference keynote in the style of Christopher Manning. And this is what it gave me. Good morning, everyone. It is an honor to be here today to speak to all of you about the exciting advancements we've made in the field of natural language processing. I'm not sure how much ChatGPT knows about me, but it certainly knows that my field of interest is natural language processing. As many of you know, natural language processing is a subfield of artificial intelligence that focuses on the interaction between computers and humans through the use of natural language. It is a crucial element in the development of intelligent systems that can understand, interpret, and generate human language. And so it goes on. And I won't read it all out, but, actually what it outlines, the rest of my talk I wrote for myself. It isn't all generated by ChatGPT. But, in all honesty, even as someone who's been working in natural language processing for 30 years, I just find it stunning how good ChatGPT is. That the outline, it's doing a perfectly good job at outlining a good conference keynote for Christopher Manning. And, indeed, it's introducing the same kind of topics I just started introducing. I also wanted to tell you about, powerful transformer models such as BERT and GPT-3. And, I'm going to go on in a minute and talk about how there are still challenges that have to do with the bias and problems of these models. It's essentially writing a perfectly credible outline of a conference keynote. So this has just been incredibly dramatic, the power of these models. And we're now, at the brink of where there are all sorts of good places where these models can be used. Here's a piece of work done by my Stanford colleagues, Minya Lee and Percy Liang. So this is taking the previous generation model of GPT-3 and embedding it in a text editor so it can be used as a writing assistant. So there are many cases in which human beings are writing text, whether it's creative writing or trying to write a news article on a deadline, and sometimes you're blocked and you'd like some ideas as to how to continue or how to phrase something. And so with this interface, you can just write, but at any point you can get suggestions from GPT-3 as to what are a few sentences or words that you should use next. And you can look at them and you can just choose one of those and adopt it, or you can decide that you don't like any of them, but perhaps still take ideas from it. And in these kind of ways, these large language models can very effectively collaborate with the human being on writing. These language models have all sorts of other uses as well. For the history of the modern internet, when we search for information, that the standard has been that we type some words into a search engine and we get back a list of links and we wonder if any of those pages will help us, and we go off and start reading them. But a lot of the time we just have a question which we'd like an answer to. And especially if you're on a mobile phone, it's not really that convenient to start trying to sift through web pages to find an answer. So using these same kind of large language models, we can instead just have our question, when did Kendrick Lamar's first album come out? And our neural network large language model can search through the web pages for us and just give the answer and tell us it's July 2nd, 2011. These kind of applications, which many people, including my own group, have worked on, can be powered by making use of large language models for all of the stages of retrieval, re-ranking, and then reading documents to find the answers. And this technology is not useful only for language. So at Stanford, we have promoted the name foundation models to emphasize the fact that this same technology can be used as a foundation that can power all kinds of different artificial intelligence applications. One of the most promising is extending the use of these models to writing computer code. So with models such as OpenAI's Codex, which is repackaged as GitHub Copilot, or also a number of other models that other groups like Salesforce and Replit are putting out. You can just write a comment as to what you'd like your piece of code to do, and you can then have computer assistants write code for you. This kind of coding assistance is way beyond what's traditionally been given by development environments for programmers, and is really extremely productive. A lot of what programmers have to do is work with APIs and libraries that have all kinds of methods and arguments in different orders that are very different, difficult to remember, and these kind of methods can just make programming much easier and faster, and people are seeing lots of speed gains from them. And then beyond that, we can go to generating images. So when making your slideshows, rather than having to use tired old clip art from the web, you can just ask for pictures and get what you want. So if I wanted to promote having wonderful public transportation, like in the Netherlands, in the Bay Area, I might ask for a train going over the Golden Gate Bridge. And this is then using DALL-E 2, produces a train going over the Golden Gate Bridge. Now, of course, the Golden Gate Bridge goes over some water, and it might have liked a picture with some water in it, so I can say a train going over the Golden Gate Bridge with the bay in the background, and I'll get a picture with the bay in the background. Now, depending on the kind of document I'm producing, I might not really want something that's photorealistic, so I could say a train going over the Golden Gate Bridge, detailed pencil drawing, and I'll get a detailed pencil drawing. And then it's perhaps unrealistic, especially in the US, to think the only thing that is going to go over the Golden Gate Bridge is trains. So I might like to still have some cars going over the Golden Gate Bridge. So I can say cars and a train on the Golden Gate Bridge, detailed pencil drawing, and get something like this. Now, not every detail is perfect if you look closely, right? This car's at a bit of a funny angle, and this one looks like a bit of a wonky loaf of bread or something. But, you know, it's just amazing already the extent to which you can get your ideas realized in images, paintings, photos that are really just being generated afresh and new by this large foundation model. And so it seems like we're going to see rapid transitions and opportunities for companies. I think, you know, things are just sort of speeding up to a scary extent. So already, you know, I think a lot of companies are fighting from getting from the stage of being traditional businesses to being increasingly software businesses. But no more sooner is that underway than really we're moving from the stage of having traditional software businesses to machine learning and data businesses. And then just as people are getting used to that idea, we're now going to have foundation model businesses. Already various companies are starting to explore using these models to be able to generate things, whether it's automatic generation of artwork in a souped up Photoshop, or something like a copywriting agency using a foundation model to generate various alternatives for advertisements that might perform better. So how scared of this should we be? Should we be afraid of an imminent singularity, the moment when machines have artificial general intelligence at or beyond human level? Now, if you live around the Bay Area in California, there are quite a few people around there who will claim that we're in this exponential ramp up of technology, and so the singularity will come approximately 2030, and we will all be completely redundant, and machines will do everything. I personally don't believe that. I think that's a pipe dream. And I think if you look at the history of what's happened in technology over thousands of years, that by and large, there have been sort of steep ups when some new capacity of technology is unlocked. But then things tend to plateau again until people make the next big discovery. So, you know, one of the early big ups in technology was when human beings discovered metalworking. That allowed all kinds of new capabilities that hadn't existed in the Stone Age. But, you know, we spent a long time metalworking, and then another big up in technology came with the invention of steam engines. That allowed not only a new form of mass transportation, but the automation of other things, such as producing fabric. But, you know, that sort of leveled off for decades. And then another big up came when we discovered electricity. I assume that the same thing will happen here. So I suspect no one in this room, no one alive today, really actually needs to worry about the singularity. And hopefully, with careful thought and design of AI systems by human beings, no one will ever have to worry about some of the adverse consequences that some people fear. Are we all going to lose our jobs? This is a difficult one. I've sometimes worried about it myself. And such worries cause humans to be afraid, which has its own negative effects for society. But it's actually hard to know. So here's a newspaper headline: March of the Machine Makes Idle Hands. Prevalence of unemployment with greatly increased industrial output points to the influence of labour-saving devices as an underlying cause. This headline is from 1928, another period when a handful of immensely powerful men dominated the United States just before the Great Depression. But in later decades, change policies led to boom years that lifted the lives of most people. Here's another quote. In the past, new industries hired far more people than those they put out of business. But that is not true of many of today's new industries. Today's new industries have comparatively few jobs for the unskilled or semi-skilled, just the class of workers whose jobs are being eliminated by automation. That quote is from Time magazine in 1961, right at the beginning of a boom decade. The available work has certainly changed, and the change in available work certainly causes social disruption and stress. But I don't think there's any particular reason to think at the moment that there will be mass unemployment. You know, if we go back to the examples I talked of earlier, when steam-powered looms came along, that caused massive social disruption. That's where the term Luddite came from. And lots of people who used to work producing homespun cloth lost the jobs that they actually had before. And that causes stress to society. There's no doubt about it. But the funny thing that actually happened was that because as a result, the manufacture of clothing was massively cheaper than it was before, people had massively more clothing options and bought massively more clothes. So the end result is that more people are now employed by the fashion industry than used to be employed in the fashion industry in those days. And maybe the same will happen again. And if that doesn't happen, well, you know, back in the 60s, we were being promised 3-day work weeks. And somehow those 3-day work weeks just don't seem to have transpired so far. It wouldn't be so bad if there was a little bit less work to be done by human beings. Will almost all the money go to 5 to 10 enormous technology giants? I think this is a much more serious worry. This is precisely the direction we seem to be headed in at the moment. There is no doubt that modern networks and a concentration of AI talent encourage this outcome. But that's sort of the same as a century ago when modern transportation networks also led to some enormously strong monopolies. Ultimately, what happens then depends on the political and social response to these situations. In the 20th century, countries successfully dealt with monopolies dominating their economy, and the question is whether there can be the same kind of political leadership to do so again. So the huge AI worries are at least far off and may never transpire. I think we should instead worry about the large problems that are already everywhere among us, even with the very limited artificial intelligence technologies that we have today. When I was young in my formative years, Carl Sagan was on TV. We'd fire up our cathode ray television and stare in awe at Carl Sagan as he expounded the mysteries of the universe. It's a different world now. Now they're remarketing Carl Sagan's book by saying, with a new foreword by Neil deGrasse Tyson. And admittedly, it's a pretty dated background if you look in this picture. And maybe Carl Sagan looks a bit dated as well. But nevertheless, I think Carl Sagan was great because as well as being a physicist, he had the heart of our humanist. And he would expand on the perspectives on human beings, saying things like, in our obscurity and all of this vastness, there is no hint that help will come from elsewhere to save us from ourselves. It is up to us. Carl Sagan also wrote many other books. Another book he wrote was The Demon-Haunted World. And I think there's passages in that are actually important for some of what's happening today. And so he writes in this book, I have a foreboding of a world in my children's or grandchildren's time when awesome technological powers are in the hands of a very few, and no one representing the public interest can even grasp the issues. When the people have lost the ability to set their own agendas or knowledgeably question those in authority. When clutching our crystals and nervously consulting our horoscopes, our critical faculties in decline, unable to distinguish between what feels good and what's true, we slide almost without noticing back into superstition and darkness. I think that that's actually the big worry for the world that we seem to be heading into in the current years. The most common place we see artificial intelligence making an adverse impact today is in manipulating our social network feeds, causing people to feel bad, or even worse, to be deceived and outraged, even upending democracies all over the world, not only in the United States in 2021, but also yesterday in Brazil. The ability to control the attention and viewpoints of people is turning out to be more powerful than explicit censorship or control. Human brains are very hackable in terms of influencing them and getting people to believe different things. And so we also have to be worried about the harms of NLP, that NLP can generate offensive content, NLP can generate untruthful, hallucinatory content, NLP can enable disinformation. To say just a little bit more about the first one, what has been found is our large language models both pick up on all the stereotypes and negative text that they read on the internet, and indeed then tend to magnify it even further. So they learn all the worst stereotypes about different ethnic groups, or in a recent piece of work by other colleagues of mine at Stanford, they showed that the GPT-3 model strongly picks up stereotypes such as associating Muslims with violence. So if asking GPT-3 to complete text saying 2 religious groups walked into A, and then doing it with Muslims, Christians, Sikhs, Hindus, even atheists, what they found was in 2/3 of the time the story that was written for Muslims contained violence, whereas for any other religious group the percentage was way, way smaller, below 15%. There are many other areas in which we have very biased systems being deployed. Another infamous one is we see AI helping judges to set bail or sentencing for suspected criminals, and it has been shown that that's biased by race. It's also problematic that a lot of these systems are closed proprietary systems marketed by companies where people can't even look inside and see what the models contain and how they're biased. Because of these negative social impacts, we've seen a proliferation of AI for good initiatives and institutes. There are two main ways I see most of the efforts going. The first type of initiative is often made up of social scientists who notice and critique the potential or real harms of AI. That is useful work to do, but that doesn't by itself help us apply AI in positive ways. It might avoid some problems after the fact, but we'd like to get these warnings earlier. How do we proactively design to avoid these issues? Typically, AI experts see important social problems like health and apply AI naively so that it doesn't actually work in practice. This has happened repeatedly, but has occurred acutely in short-term crises like COVID-19. The headline saying hundreds of AI tools have been built to catch COVID. None of them helped. It has also occurred repeatedly over the longer term. For example, in 2016, Turing Award winner Jeff Hinton said we should stop training radiologists now as AI will easily surpass humans within 5 years. That did not work out. Nor has it worked out in AI skin cancer detection, and not for AI in other applications to medicine either. Often there are differences between the ideal data sets on which AI researchers train their models and the messiness of the situations found in real-world hospitals. Often researchers don't even solve the right problem. My colleague at Stanford, Kurt Lenglotz, who's a radiologist, writes in one of his papers, "Will AI replace radiologists is the wrong question. Instead," he wrote, "the right answer is radiologists who use AI will replace radiologists who don't." The big problem is how to design AI systems to have positive human impacts. So that is one of the main things that we're trying to focus on at Stanford in our Institute for Human-Centered Artificial Intelligence. How do we get positive outcomes from AI? What would it have taken to have avoided some of these negative outcomes like Compass's AI-assisted sentencing or ineffectual outcomes like current uses of AI in the COVID crisis? To avoid these outcomes, we must design and analyze these systems at 3 levels in conjunction in terms of the user, the community, and society. I believe that if we do, we will create technology that has a better chance of making a positive input. Human-centered AI is about the scope of who we study, to find problems, develop solutions, evaluate systems. The first stage of that is to have a user-centered process, to integrate well-known techniques from human-computer interaction and design that account for the needs and abilities of end users of computing systems early and often, and to rapidly iterate and improve a design through rigorous testing. But we need to go beyond just having a good user-centered design process. As has been illustrated by some of the harmful examples I mentioned previously, we can't only design around the user. That would be like, for the sentencing system, giving a good UI to the judge. That just isn't sufficient by itself because it doesn't address any of the systemic issues in the legal system. We also need to take into account the community that's impacted, the people who are accused, their families, the lawyers, the victims, their families. We need to understand the issues of the different communities that come in contact with the legal system and the structural barriers they face. But even that isn't sufficient. We also need to understand what the impacts are on society at large. What does it mean to have a large population in prison, as in the United States, for example, or a huge racial imbalances in the percentage of different racial groups that are in prison, also in the US? Or what happens when you put lots of people in prison for being caught using illegal drugs? These are issues that have huge societal impacts, and so we need to take a societal level approach. So to be able to do this, we need to not only have AI technologists working on these problems, but much broader interdisciplinary teams, which make use of the insights of sociologists, psychologists, lawyers, people in business, people in philosophy, many other areas of society to get different perspectives in the design. And these people must be true partners in the design of our policies. So as part of that, one of the things that we've really been emphasizing at HAI is trying to reach out so that more knowledge is spread beyond AI researchers. And so we've been increasingly trying to focus on doing outreach to government, to journalists, and civil society. We're also wanting to create more in the way of multilateral institutes where there are opportunities for sharing knowledge around different countries of the world. Overall, we need to be having more international cooperation to establish norms in AI, to unleash innovation and economic prosperity in different parts of the world, and to develop applications of AI that benefit humanity in a much more general way. Thank you.
So I'm actually only here to sort of welcome Marietje Schaake to the podium, to the stage, but to remind you that there will be plenty of time to ask Chris Manning questions about his lecture and enter into discussion afterwards. So do remember your questions for in a moment or so.
Thank you very much. Hello, everybody. Welcome, Chris, and congratulations. It's not often that I feel both so at home in Amsterdam, where I've lived for 25 years, at the University of Amsterdam, which is my alma mater, and also feel as a guest, because as a former politician, I am a guest in academia. I'm also a guest, so to say, at Stanford, where I'd like to think of myself as one of those people in interdisciplinary teams, because I'm not a researcher, I'm not a professor. And so it's always a little bit awkward to say something about the very complex topics that people have studied for decades as somebody who really comes in as an outsider. Now, I have spent 10 years in politics. I do also now write columns, so I thought I would contribute to this public symposium here at Spuit 25 in a sort of column form, and to then invite more interaction, which I always think is valuable. It allows you to ask questions, but also creates a bit more, back and forth between the esteemed academics, professors here, and myself. So let's see where that brings us. We've all witnessed, I think, the transition in thinking about artificial intelligence from hopes and promises to much more focus on concerns. Those have been prompted by outcomes of artificial intelligence and also more vocal participation from minority populations, for example, in the debate about what we might actually see resulting from AI, not just what clever marketeers and Silicon Valley CEOs have marketed. So it is important to understand how we might distinguish between the intended discrimination that AI brings us or unintended discrimination, which would be, for example, illegal, and is thankfully the subject of growing scholarship and scrutiny. I think we should assume that AI acts within the law. But that is more easily said than done. And on top of that, there is the challenge of how we might develop new laws where the existing ones simply do not cover the new realities created by artificial intelligence. Now, a tendency has been, and I think for understandable reasons, to zoom in on individual harms. How might a prisoner, Chris mentioned it too, be wronged when AI labels them as high risk of committing more crimes or thus less eligible for parole? Or what about the mother living on welfare who is identified as a fraudster? The lack of access to information about the systems and the decisions that they make has been seen by lawyers as a very problematic development. And they have said it really eats away at the notion of the presumption of innocence. And what's more is that the suspects in some of these cases are completely unable to access any information that has prompted the decision about their labeling as recidivism likely individual or a possible fraudster for that matter. And I do think that that touches upon a more horizontal challenge. Jelle has mentioned it. It's the question about transparency, a very hot topic when people scrutinize artificial intelligence. We need transparency. But I want to talk a little bit more about the notion of transparency because I think it is not as straightforward as that sounds. Because it's not only difficult to know what data went into the training of artificial intelligence systems and applications, or what settings may have caused bias or harm. But it is generally very difficult, if not impossible, to gain insights into the inner workings of AI applications. Chris hinted at that too in his talks. I think one of the key reasons is that the data, the settings, the knowledge and the insights are in the hands of companies, and companies treat all this information as trade secrets, the same as Coca-Cola treats its recipe. If it would be known, competitors would steal it, and away it would do with their big profits and their unique position. But what's more is that companies, and this is also a feature of artificial intelligence, so something that we really have to wrestle with, are constantly changing and updating their settings. In fact, new iterations can almost automatically, if not automatically, lead to new settings of an algorithm and so on. So it's a very fluid and dynamic process. Take, for example, as a consequence to look at here, Facebook's or Meta's content moderation of its social media platform. Some people, maybe many people, have been rightfully angry about the decisions that the company has made, leaving Holocaust denials up when eventually they said these would be taken down, or how COVID disinformation was fought. Not only because there were lies or fraudulent solutions online, but because they would keep popping up even if the company said they would be taken down. It is entirely plausible that the company itself had lost track of the head and the tail of its content moderation, of a very highly complex product that we should probably think about as a house of cards that has kept expanding, extending, and changing, and then leaking, and then being repaired, and so on. Engineers at the company, in fact, have told me that they themselves do not know how the algorithms work, and Motherboard reported an employee as saying, "We do not have an adequate level of control and explainability over how our systems use data." This was a quote from a leaked document. So good luck to any journalist or lawmaker or human rights activist who wants to understand how this platform works. If people on the inside don't know, how would people on the outside know, especially without clear rules on spelling out how that should be done. Now, with social media companies, and that's perhaps why platforms get so much attention, some of these harms are visible. We see them in society, we experience them ourselves, we can imagine what they mean, because we almost all use these social media platforms. But of course, there are endless applications of artificial intelligence that are not as easily visible and that are not as relatable as the use of social media. So it will be harder to know that a harm might be taking place. It will be harder to anticipate what the harm might be. It would also be harder to have political pressure to change the harm because people don't experience it themselves. Now, I would like to look to three related challenges that new policies around artificial intelligence and transparency will have to deal with, which is one, access to information in the public interest. It was also mentioned by Chris. So transparency for a variety of purposes. We shouldn't think about transparency as posting a code here on a screen and everybody looking at it transparently, because it would probably be impossible to even know what to do with it. Transparency often has a purpose. access to information for freedom of information of journalists, for example, access to information for oversight of quality of a product or the safety of children, for that matter. So that is one, access to information in the public interest. Two, understanding the information once the access is gained. There is enormous complexity in these systems. We've seen it, enormous capital going into it, only very few actors truly having a grip on these AI systems. And so who has the expertise to actually look at them objectively? And then there's a question of being able to relate input, settings, output, while we have that constantly changing dynamic going on, which is, I think, inherent to artificial intelligence, but what does that mean? So if we stick to the social media platform example, how do I know that I might have been discriminated today, or was it 3 weeks ago? And what does it mean for any of you? Because we each have a mirroring of unique settings determining our experience. And so even an oversight body or an enforcement agency would essentially have to know each one of your different experiences in order to assess whether you've been wronged. Whereas that would be very different if a commercial on television, for example, discriminates against a certain category of people illegally. So I think there is a lack of clarity currently on these three questions that I just posed: access to information, the ability and skills to scrutinize, and the fluidity of AI, which all have consequences for notions of redress, so how to claim your rights, and accountability over these systems. Now, commercial companies, but also engineers, understand that there is eroding trust in the applications that they are building and selling, and that there's a need for answers. And I'm sure that many people are extremely motivated to provide societal solutions through AI themselves. But, of course, there are also those who, and I think we've seen plenty of those in Silicon Valley, who see the law as an obstacle that should simply be worked around. And once it's worked around, then, well, the law doesn't forbid it, so let's go ahead and build it. Now, there is no lack of self-regulatory initiatives, but also ethics declarations. You may have read them somewhere or seen them presented with pride in a company or by an international organization, or perhaps even in academia. And in a positive scenario, such self-declarations or ethics guidelines will ultimately lead to harder and more enforceable rules. But if we look at this development of loads and loads of ethics declarations in a slightly more cynical light, these can be used to shield the very accountability by pretending that they are the real thing. Even the US government has recently adopted an AI Bill of Rights. Very promising, because it invokes the iconic and powerful actual Bill of Rights. But the AI Bill of Rights is not enforceable, it doesn't actually grant rights, and so it's not even really a bill. It's just a set of guidelines. Now, another solution that we hear when listening to AI experts is to have a human in the loop. Apparently, the thinking must be that when there are machines on the one hand, then adding a human on the other side will create balance and oversight. But what this notion misses is the politics of trade-offs, and I'll say more about that later. Because we have to ask ourselves, with what authority does the human operate? Do they sit and watch the AI run the way that an operator of a machine in a toy factory watches whether all the skippy balls come off the conveyor belt in one piece? Are they highly skilled engineers trained to probe and question the AI and even adversarially dig into it vis-à-vis, for example, the commercial bottom line of the application? And from a democratic perspective, designating a human to represent all humans is not exactly sound either. The EU, I'm sure you've read about it, has initiated a binding law. So no AI ethics guidelines, not humans in the loop necessarily, but an AI Act, a binding law. Independent oversight is foreseen, and I believe that that is ultimately what is needed for the AI butchers not to test their own chops. But with the AI Act, the application of AI is leading. And then there is a rank of risk from very high risk to essentially no risk in how the AI is used in society. And then the answer is whether the risk is acceptable or unacceptable. So, for example, social credit scoring would be considered high risk and therefore unacceptable and banned, whereas AI use in chatbots for your customer service online, for example, would be considered low risk. Now, it is too early to draw strong conclusions from a law that has not quite entered into force yet, but I will venture to share a few risks to the law itself that I think we can already discern. One is only looking at the applications of AI risks missing some of the more fundamentals of the technology that Chris works on and has spoken about. Fundamentals such as ownership, agency, compute, data, and capital. These factors too can create dependencies that are significant, but also concentrations of power that are undesirable from the perspective of the public interest. Another element of the AI Act, which shouldn't escape us, is that the military use of AI has deliberately been left out of the new AI law. Now, that can be a fine decision, but if you look at the global context in the United States, but also in China, it is precisely those military considerations that are driving much of the development of artificial intelligence. And so you have to ask yourself, how helpful is it to not have the law speak to the military application of AI? Now, within the EU context, it's all understandable. There's much more power in the EU, on the EU level, for single markets and economic harmonization than there is for national security. But I do think it is a risk in the law that it would really be off balance vis-à-vis geopolitical developments. 27 countries will make their own decisions about what investments and applications in national security context are helpful and how they might be used, for example, in conflict. The conflict context as a notion that is changing rapidly has big implications for how we use technology and also AI and how the law applies. Because unlike kinetic wars, the kinds of wars where we see tanks like the ones from Russia rolling over the border with Ukraine, in the digital domain, lines between war and peacetime, civilian and military technologies, but also economic and geopolitical motives are very much blurring. And AI will be at the heart of some of these slippery slopes, where clear legal guidelines are needed to clarify who holds the mandate to use force, with which goals, and with what types of accountability. Now, I've said a lot and I'm going to conclude, but I'll come back to the notion of the politics of AI. When I served in the European Parliament, the only lens through which we looked was a political one. And I think sometimes when I listen to AI experts or the whole discussion about the role of AI in society, I miss the very political reality that will be unavoidable as well for AI. I think it cannot be denied. And I hope that democracy and the public interest won't be denied either. And I really liked Carl Sagan's comments, very visionary already. Because no engineering team, no ethics declaration, and not even a good policy proposal can brush over the very real matters of values going into artificial intelligence and the applications, or the trade-offs that need to be made between different objectives. And this is not only about AI as a technology itself and its various use cases or harms, or use cases or harms, but it's also about the context within which it's going to be used. There are questions of representation. Recall that human in the loop. But also imagine the democratic process going into electing that very human, or answering the questions of whose behalf they operate on. There's questions about who gets to decide what is responsible. We all like the sound of responsible AI, but the political question is who gets to decide what is responsible and how do we decide it? Both Jelle and Chris talked about it. Or what is a positive outcome, as Stanford High, where both Chris and I work, strives to aspire. People fight for days, if not centuries, about the definition of positive. What is good for you may not be good for me. And how do we make sure that all the things that are good for us all fit within the budgets, within the operational capabilities, within the choices that we have to make? These are the questions that I think we need more attention on. You can see the battles, the peaceful ones, every day in parliaments, in the city council down the block, summarized on the evening news or in tweets, that humans do not tend to agree easily on who they're represented by, but also on questions of who should pay, how to ensure that technology policy, but also healthcare, education, and national security, all very important, are all taken care of. So when we think about regulating AI, let's think about doing so along the pillars of the rule of law and democracy, with independent checks and balances and oversight, the protection of actual rights, in particular to protect minorities and the most vulnerable. If that is the lens through which we look, and we appreciate that that is a political one, then I think we will be working more closely towards having solid benchmarks within which AI can flourish, the benefits, but also the containment of the harms. Thank you.
Thanks so much. So I actually have a long list of questions that I want to ask you at some point. But I think in the interest of time, I will keep it very short. So I will ask just 3 questions to you now, and then give the floor to the audience here as well, if people want to. So if you have questions already, do try to formulate them so that we can go fast in a moment. So I want to start with you, Marietje. Thanks for that very nice column speech that you just shared with us. And I think we're very much on the same. I think we very much agree on the need for, say, scientists, engineers, politicians, policymakers to actually collaborate on addressing the concerns that you so nicely shared with us. But what is it that you what would you ask us scientists to do? Like, how do we make that collaboration actually happen? What do you think should change? We should change about the way we communicate, or the way we do our research to really make that work.
It's really the billion-dollar question. But let me give a couple of points. When I just arrived at Stanford, I went to a presentation of a talk by somebody who had just left Instagram as an engineer. And the talk was about the power of the company, how the work on the inside looked, but the notion of moving markets came up a lot. You know, how when Kim Kardashian presents a lipstick in her first post in the day, the lipstick company can really assume selling, I don't know, millions of lipsticks the next day. So Instagram is able to move markets. And now, being the former politician that I am, I was more interested in moving masses. So not just markets, but masses of people, and in the context of the democratic process. So I asked, how did the engineering teams at Instagram consider whether the settings of the algorithms and the way they presented first posts or selections of posts could move masses? And the presenter, who is a wonderful person, asked, what do you mean by the question? Well, I said, how often in the engineering room were you talking